Thank you for joining us for our November webinar, and happy National Prematurity Awareness Month. For those of you who are joining us for the first time, I'd like to extend a warm welcome and remind all attendees that a recording of this webinar and all slides will be published on our website, fcctaskforce.org, as well as shared in a follow-up email, which we encourage you to share widely with your colleagues. Today's webinar honors Fabiana Bacchini's 26-weeker twin sons, Michael and Gabriel. Michael was born sleeping, and Gabriel is 12 years old. Thank you, Fabiana, for using your family's loss and pain to help others in the neonatal space. This work wouldn't be possible without our esteemed organizational partnerships. It's incredible to see so many parent-led organizations alongside prestigious medical associations, and the amalgamation of these partnerships is part of what makes the FCC Task Force so special. I'd also like to acknowledge Reckitt Mead Johnson, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, RMJ, for sponsoring this webinar. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser's Next Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy and empower everyone to contribute. Please take a moment to review our webinar etiquette. We ask that you mute your microphone when you aren't speaking, that you turn off your camera if you're multitasking, and that any questions and comments spoken or written in the chat be respectful, non-discriminatory, and non-judgmental. We also ask that attendees refrain from any commentary on the Israel-Hamas war during today's presentation. We appreciate your help in making this space as safe as possible. As we move on to FCC Task Force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Malathi Balasundaram and Colby Day are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, and myself are former NICU parents. Thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing and non-birthing parents, bereaved parents, and even adult preemies. I'd also like to thank our healthcare partners for their time and support. It's rare in our local units to witness such authentic collaboration between the various disciplines of practice you represent, and we appreciate that you embody our key strength of equal partnership between all healthcare professionals and family partners. It is with deep sadness that we share Ada Simonian, CEO of PACLAC, and a valued member of our Executive Council of Healthcare Partners and a member of our Advocacy Committee, has passed away. Many remember Ada as a champion of perinatal quality improvement, dedicated to medical advancements in family-centered care and leadership. I'm compiling tributes to Ada for our November FCC column in Neonatology Today. If you'd like to contribute, please email me. I'll be sure to drop my address in the chat. Ada will surely be missed by many. We'd like to thank Christy Love, Executive Director of National Perinatal Association, for her time on our Executive Council of Family Partners. Christy, we sincerely appreciate your contributions to the FCC Task Force and are excited to welcome your colleague and NPA's Director of Communications, Erica Goyer, to our leadership team. Erica, we look forward to utilizing your unique skill set and perspective to advance FCC Task Force initiatives. The FCC Task Force is supported by its subcommittees, co-chaired by one healthcare partner and one family partner, respectively. Daphna and Alex of our Marketing and Communications Committee manage our Twitter, LinkedIn, Facebook, and Instagram accounts. please take a moment to follow us. They do a great job of sharing our work and events and news taking place in the NICU FCC space. Myself and Vargabi collaborate with a variety of contributors to publish a quarterly newsletter, which includes actionable takeaways for implementing FCC, a trauma-informed care corner, recommendations, and other free resources. Advocacy Committee co-chairs Carrie and Nicole keep our task force working toward big picture initiatives like zero separation and unlimited access to parent and family caregivers, and smaller but equally as important projects such as supporting paid family leave in the United States. Our newsletter committee published their fall edition late last month, and we hope you'll take a moment to read it if you haven't already. Many FCC task force members report experiencing more buy-in around FCC practices in their NICUs after sharing our newsletter, including printing and posting it in their unit. Please share this publication widely and continue to share your success stories with us. I'll be updating the chat with a link to this QR code and the ones you'll see on the next few slides, so no need to panic if your cell phone camera isn't immediately available. I'm happy to share that we have over 1,700 members from 48 of 50 US states and Puerto Rico, 8 of 10 Canadian provinces, and across 58 countries. As the person who updates and measures our membership regularly, it is incredible to watch this organization grow each week. We've presented 16 webinars so far, with this being our 17th. Please utilize our webinar database located on our website under both the webinars and resources tabs to view and share all past FCC Task Force webinars. We encourage you to share these widely with your colleagues. Our October poll question comes from a neonatal therapist in Ireland. They ask, if you are a neonatal therapist with an active role in FCC implementation in your NICU, please share how you were able to get involved or be included. Do you have any advice for neonatal therapists experiencing pushback around their presence in the NICU? And again, I'll chat this link in the Zoom meeting. Mark your calendars for our upcoming office hours sessions. These are informal virtual opportunities to share your NICU struggles and barriers around beginning or strengthening FCC in your unit and brainstorm ideas for overcoming them. Our meetings are casual yet impactful, and we encourage you to register and join. Last but not least on my list of updates, how do you know you're truly delivering FCC in your NICU? The FCC Task Force's Executive Council of Family Partners and Multidisciplinary Healthcare Professionals have created a comprehensive survey to measure FCC in the NICU. To receive the survey link, scan the QR code or use the link I'll be entering in the chat. You will receive a copy of your responses immediately following completion and will have an opportunity to meet with FCC Task Force leadership to review your unit's results. Please don't hesitate to email myself or Malathi with any questions. We hope you'll participate in this pioneering work. With that, I'd like to hand it over to Malathi to introduce our first speaker, Rafael Mendelsohn.
Thank you, Morgan. It is my absolute pleasure to introduce Rafael, and he's a neonatologist and medical director at Tel Aviv Medical Center. He completed his medical school at Semmelweis, Budapest, Hungary, and residency at Tel Aviv Medical Center, and fellowship at Mir Hospital, Kfar Saba, Israel, and Children's Hospital of Eastern Ontario, Canada. And if you're new to Task Force, I want to give a little background. And we had a small group QA collaborative model in 2023 with 5 small groups, each led by neonatologists and family partners. I'm proud to say Rafi was in my group and actively participated in our monthly meeting. Though it was a bedtime for his kids, he sometimes showed up at his kids when his wife worked the night shift and didn't miss a single meeting. He reached out to Bob and how to incorporate FCC into NICU designs. He built his unit FCC program from scratch, which you will hear about it momentarily. he is trying to sustain the efforts in FCC efforts in his unit, given current state in Israel. I had a great time collaborating with him, and I think Kira, Bob, and Michelle will agree too. When I started this task force, my goal was to help one more center form the program similar to my local unit. He fulfilled that goal, inspired me to keep doing what I do to motivate others to implement FCC. Thank you, Rafael. So take it away.
Thank you very much. So let me just share my screen. Okay, there we go. Okay, so hello everyone. My name is Rafael Mendelsohn. I'm a neonatologist in Tel Aviv Medical Center. I'm extremely excited to present our long and winding road through cultural change in the NICU. Why is that not responding? Okay, so I have no conflicts of interest and nothing to disclose. And this is my grandfather. He's a Holocaust survivor. He lives in Munich, and he just turned 99 this September. He was a great inspiration to me throughout my life. And he used to tell us a joke about a Polish friend who's moving to the States, and everyone tells him that now that he's in the States, he needs to polish his English, and his response is that his English is Polish enough. So I want to apologize in advance for any English or grammar possible mistakes. And I might talk fast because I have a lot to say and not too much time for it. I want also to thank the Family-Centered Care Task Force for this opportunity to present our progress and for all the guidance and support I've received throughout the last few years. I'm going to talk about a little bit my background, then our NICU, then some challenges that we've encountered along the way, some steps that we took to implement cultural change, and of course, you can't live in Israel and not talk about October 7th. I'm going to talk later about some key points that facilitated the change and some plans for the future. So as I mentioned, I did my medical school in Budapest, Hungary, then did my residency in Tel Aviv Medical Center, where I fell in love in neonatology. I did my fellowship in Kfar Saba, Meir Medical Center, about 20 minutes from Tel Aviv, and it's a NIDCAP oriented and a NIDCAP teaching center. So I learned a lot over there. Then we packed our things and moved to Ontario, to Ottawa. You can imagine my wife's happiness level when we moved to one of the coldest capitals in the world with a 1.5-year-old and 1 month old. And I was having about 7 or 8 calls per block. Altogether, it was a great experience. And then I came back to 2 more years in Meir Medical Center. And in 3 days, it will be 3 years to my return to Tel Aviv Medical Center as a medical director. And I have above me the chief of staff of both neonatology and the nursery. So our unit, I'll talk a little bit about that, we have a 23-bed, probably it would be a level 3. So we will not have ECMOs, unfortunately, and no cardiovascular surgery. But otherwise, we resuscitate 23, 24 weekers and above. We have high-frequency ventilation. There is no jet in Israel. Of course, we do cooling, and I believe that all the rest of the standard things done in most of the world. In Israel, we have no, this area, which is written with number 1, is the high acuity area, and this area is missile proof. I'll talk about it a little bit later. And then in Israel, there are no transfers, basically. Where the baby is born is where he is discharged from. So we have a 20-bed for step-down unit. That's area number 4. And after growing and being ready for discharge, babies are discharged from here. As a team, we have 8 neonatologists. We have 2 fellows. We have 2 neonatal nurse practitioners who just finished their education and will start. Actually, one already started, and the other one will start next week. We have 8 residents who come for an 8-month rotation. They do 2 months in the nursery and then the rest in the NICU. We have 55 nurses, again, a bit different from North America. They work an 8-hour shift, morning, evening, and nights. and one nurse has about 2 to 4 patients in the high acuity area, and we get to a nurse per 6 patients in the step-down area. So not optimal. In terms of our other team members, so most of them work at part-time, unfortunately. That's what we are given from the hospital. So we have a social worker at 75% capacity, psychologist at 50. There are no respiratory therapists in Israel. Their work is divided between the nurses and the physician. We have a designated pharmacist, but we mostly get pre-ordered TPN, so not done custom-made on a daily basis. And the nurses usually do prepare the antibiotics. We have a dietitian at 75% capacity, mainly for the lower weights babies, and PT and OT at, again, not at full position, unfortunately. And those teams as well, let's say the occupational therapist is not one coming for half time. There are 4 or 5 that rotate between them and come to our unit. And again, unfortunately, no lactation consultants in our. So that's our 3-month schedule. As you can probably see on the right-hand side is our names. And then the rotation, we do 2-week rotation. So we have 2 weeks in the nursery, 2 weeks in the NICU, 2 weeks in the step down. Again, 2 weeks research, NICU, nursery, and support. And when I write support, it's usually either helping in the nursery. You'll see that we have a very busy one. Or covering up for people that are on vacation. There is a lot of clinical work in Israel, and unfortunately, not too much time for teaching, planning, administration, research, and etc. In terms of the daily routine, so we all gather up in the morning. We go over in the morning meeting. All the team goes over the patients in the NICU. We make some plans, and then each physician has his own patients. He go over them with the residents. So again, the daily routine is very, very different from the one I've met in North America. In terms of admissions, so again, nursery, we have 12,000 deliveries annually, which comes down to about between 25 to up to sometimes 50 daily admissions and discharges. So very busy nursery. And then in terms of admission to the NICU, so to get admitted to the NICU, you'd have to be either a term with oxygen requirements or IV fluid requirements, or 34 plus 6 and below, or less than 2 kilograms. Actually, recently, the last few months have been not very busy. We had 35 admissions in September, 38 in August, and you can see the division. Let's say in September, we had 2 babies born less than 1 kilogram, 2 babies between 1 kilogram and 1 kilogram 500, 5 babies between 1.5 and 750 kilograms, and the rest are at larger weight. So 24 babies at weight of more than 1 kilogram, 750 grams. We have some outborn patients arriving to our unit, mostly in neurosurgery, some neurological, some surgical ones, but mostly we have an inpatients. So arriving from a very NIDCAP-oriented unit, I remember stepping for the first time to the Tel Aviv Medical Center NICU, and I was quite shocked. I remember that the lights I felt that they were very strong. There was a lot of noise, and there were a lot of gaps that I noted while spending my first few probably days and weeks in the unit. I remember that there was a gap between how I thought we should treat patients and how we did it at that time, and sometimes still. I remember having a visitor around after 2 months I was working, and I remember feeling quite ashamed of the way that we treat our patients. The key gap points I found were associated mainly with family-centered care. So lights were always on, the ear was always red. The approach, I would say proactive, but I think it was even more than that. It was a bit aggressive. So a lot of chest x-rays, a baby on CPAP was probably x-rayed at least 2 times a day. A lot of blood work, baby on high flow support, even if it was 3 liters per minute, had at least 2 pokes per day for blood gas. The parental involvement was very minimal. So between 8 to 12, there were no parents allowed due to rounds. kangaroo care was not very common, and of course there was no babies taken out, babies on CPAP taken up for skin to skin. Twins were separated. I mean, they didn't lie next to each other for risk management causes. Unfortunately, this still happens today. And in terms of the work environment, so residents were almost not involved in the communication with the parents. They were educated to have a proactive, not to say aggressive approach. And there was very stressful environment for everyone, for parents, for residents, for nurses, and there were a lot of aggressive team dynamics. It was almost a toxic work environment. I remember asking, what about NICU? What about developmental care? And everyone told me, yes, we are practicing it. We do kangaroos. We don't poke them too much. And I realized that it's a very fluid definition. They say that light shines bright in the darkness. So I realized that on one hand, it would be very easy to make changes. I mean, every small change that I would do would probably have a lot of impact. But on the other hand, I realized that making a true cultural change would be very, very challenging. And I think it still is, but we are on our way there. It was quite clear that old habits had to change, and change is coming. And I felt that most, or at least a large part of the team was with me, but I felt that we needed guidance. At that time, I met the Family Centered Care Task Force. I think first encounter was via Twitter, I'm not sure. And at the time, we were 32 centers, 20 states, and me. I remember always feeling bad for people that in North America had to adjust to Jerusalem time. I remember me joining, as Malathi mentioned, the sessions while everyone were in their offices. I was in bedtime with the kids in their pajamas. And I especially remember the May webinar. I think it was the first one that discussed trauma, separation, developmental care, and a lot of things that I felt like it was the language I was looking for, like the expression of what I didn't know how to express. During those sessions and during both seminars and discussions, I learned a lot about family-centered care components. I received a lot of ideas, a lot of reassurance, a lot of guidance, and a lot of support regarding how to implement change. I also realized that every center is different. Every unit differs with the population, with habits, with resources. And I realized that we'll have to find our own path to becoming a family-centered care. There were a lot of challenges. I'll talk briefly about some of them. So I think the main ones were that old habits are and beliefs are very difficult to change. It's difficult to change the daily work of someone who worked at a certain way for more than 20 years. It's very difficult to make the team see things from another aspect or another view. There was a lot of team discomfort working in the NICU with probably one of the most vulnerable populations, trying to get the acuity down. So less chest X-ray, less blood work is very challenging, and it causes a lot of discomfort. We have very limited resources. So having a nurse with 4 babies on respiratory support and trying to convince her that we can maybe take one of the babies out to kangaroo care when she has never done that before on CPAP is very, very challenging. Recruiting local team was difficult because all of the mentioned challenges, and language barrier was also there because most of the people in Hebrew do know English, but I think that not enough to feel comfortable to join seminars, to read articles, and it was definitely challenging. Knowing how Israel works and knowing that we are not well organized and structured, I remember that I decided to say yes to any initiatives. I told the team, let's start working on that and take any initiative that comes and see what sticks. I think that on one hand, it was very good because it brought a lot of people to join us, and it opened the circle of the people that were interested. There were a lot of initiatives, but on the other hand, sometimes the plate was too full and it was difficult to control all the projects. in terms of what we did. And when I say did, I'll talk about it later, but most of the things we did were in the first 2 years since my arrival, as the last year was extremely challenging. So in terms of staff education and support, we have nursing team meetings every other month, probably, where we introduce the family-centered care elements. We had graduate parents come and share their experience and reflect to the team how they felt during their hospitalization. We recently had a reflection session. We took sentences that nurses tell families, and we discussed with the team how it can be said differently, or how it's better to present those things. We have monthly multidisciplinary team meetings where we try to have focus groups, kangaroo care, quiet times, etc. And we have a monthly simulation. We have a simulation center, and we have a few teams going every month, both residents and nurses. They practice NLP, they practice a clinical skill and a communication scenario, and this is very, very helpful. We try to encourage staff to join the family-centered seminars, again, not with a lot of success, and we discuss issue during rounds. I think that's very, very helpful, both during rounds, during handover, raising up the issues that you want to focus on helps push those areas and bring them into awareness of people. The recent joined neonatal nurse practitioners, I'm sure there'll be a very important chain to facilitate education of the staff. These are hats that we made to increase awareness for quiet times. In terms of mental health professions, so we have a unit-specific social worker and psychologist. They do amazing job. They attend handover. They are much more involved in the daily routine than they were before. At least that's what I'm told. I haven't been there before. We have a designated WhatsApp group to alert them at real time if there is a new admission, if there is a new deterioration of the baby, and they run the communication simulations. They have discussions with the teams. They have a monthly discussion with the residents for 1 hour. They sit with the resident and talk about whatever the resident want to bring to the table. They have bi-weekly session with the nurses, and we recently started a project of parent admission and communication. We realize that when parents are just being admitted, we talk to them about how to wash their hands, what are the entering hours, how they should dress, who is allowed in, and we don't talk with them about their baby. We don't reassure them enough, so we are currently working on that. In terms of peer-to-peer support, so we have, again, a parent WhatsApp group. WhatsApp is very strong in Israel. So parents of the NICU have their own WhatsApp group. We make the first connection. There is a parent committee that we are building, and hopefully within a month or two, we'll have our first session, and we're very excited about that. And there's a NICU parent NGO in Israel. And again, we make the first connection, and it gives them a lot of resources and support. Family-centered developmental care, probably our largest challenge, but on the other hand, I think we've made a lot of progress in that aspect. So we place a lot of emphasis of kangaroo care. We change our protocol. We have active discussion and handovers, and we try to apply four-handed care whenever possible. We now have quiet times and dark times in the NICU. We decreased the amount of pricks and pokes and X-ray tremendously. We've done a great job over there. And we examine baby only on handling times. Again, did not happen before. We have a nice project, octopus dolls. I don't know if anyone knows it. There are octopus dolls that are knitted by parents and volunteers. I think this project runs in other hospitals in Israel and a little bit around the world. It doesn't have a lot of evidence that it helps the baby. They receive it when they go to the step down, but it's actually very important to the parents, and they love this project. And it's actually an initiative of this mom. This mom tried to push it, and I realized that it's important for them. We met with members in the hospital of infectious control and risk management, and we got all the approvals, and we started this project, and parents love it. The physiotherapists and occupational therapists are much more involved. They used to not enter the high acuity area, only the step down, and now they attend and go approach parents at a much younger gestational age and an earlier stage of the admission. We have sent a few nurses to a NICU education at my former hospital, and I hope that will bear some fruits as well. That's one of our first ET tube kangaroo. That's a mom of a baby with listeria, and we take care of dads as well. That's the same baby, mom and dad. And that's a very moving story about a baby. Parents that their baby did not survive, but they had a very strong and exciting skin-to-skin experience that they've embedded a kangaroo on the baby's grave. We have a new parent booklet that we give the parents once they're admitted, with a lot of information about the NICU. We have a reduced price hotel that actually not us, it's something that new that the hospital brought, but we are using it and utilizing it a lot for the parents to be close by. Admission routine, I just mentioned that we are working on that, and we also have name notes that are hanged on the baby's bassinet, so we can call them by their private names. And of course, we celebrate whenever we can. So that was Purim, which is probably the equivalent of Halloween. The babies got a suit that resembled the physician's one. Kangaroo Week, whenever is here, we mention it. And that was Family Day. Every baby had on its crib a small postcard that he wrote to his parents. And that was like each of them was specific for the baby itself and his story. In terms of post-discharge follow-up, so it's a great challenge as we have very limited resources. We have a more thorough discharge preparation for all babies less than 32 weeks of gestational age or ones lower than 1 kilogram 500. And we also know that in Israel, they have a very good, very available and reliable both local health services and a good weight follow-up and vaccination program. So we know that they are discharged into good hands this way or another. Any subspecialty follow-up is done within our hospital, so ophthalmology, head ultrasound, etc. We used to give parents a Polaroid picture on the day of discharge. That was a very nice project that ran for a while. And these are parents that saw that we are having quiet times and dark times. And they, as a goodbye present, they handed us a speaker and a playlist for scan. In terms of palliative care, so I think we do need some further attention and work required over there. In Israel, you can't change the goals of care, so you can't extubate a baby actively. You can only non-escalate care, which is a little bit different and more complicated. There is a new position statement by the Israeli NICU Association, and hopefully we can send one of our physicians to a fellowship in palliative care. And then came October 7th. So October 7th changed everything. And last year hasn't been very productive in this aspect. Initially, there was shock. We were all shocked. There was a lot of fear of missiles being shot at all of the country, fear of whole area war, fear that Israel will cease to exist, and fear of terror attacks within the vicinity of the hospital. So missile alarms was happening initially a few times a day on a daily basis. Luckily, the NICU is missile proof. So whenever there was an alarm, we used to take all the babies from the step down unit into the high acuity area. As you can see, after getting used to that, we learned to smile during those events, and we even did not turn on all the lights, so only partially. In the beginning, there was no daycares, no afternoon activities for the children. Residents and fellows were on military service. That's our fellow. He spent more than 200 days of military service in the last year. We had family members of team members on military service, so husbands, kids of physicians, so everything was very complicated and logistically difficult. And we had some team members who lost their loved ones. War routine. This has been going on, unfortunately, for more than a year now. So it's a constant stress, both for the parents and for the team. Fear of missing out is an understatement. In the area where the parents have the relaxation area, there is a TV that broadcasts the news around the clock. So not a lot of relaxation over there. It takes a lot of processing. It's very, very difficult to focus in any task in the last year and a half or a year or such. And it's very difficult to start and accept new initiatives and changes. There is loss of creativity, of course, loss of motivation, and even the things that we do mention are not as celebrative or not happy as they were before. We feel that it's not the time for change. So again, most of the changes I've described happened within the first 2 years since my arrival, and the last year hasn't been wasn't much of a change. Other changes we've experienced. So we have still team members that are called for the Army recruit. We have an occupational therapist that was recruited for rehabilitation and left us. We have a physiotherapist that left Israel to live in Europe. We now have a neonatologist that today was her last day in our unit. She's moving to the US. And not associated with the war, we had a new charge nurse. We had a step-down charge nurse that got a new position in the hospital and left us. And our social worker is leaving for a doctoral degree. So all changes took a bit of a different aspect. If I spoke earlier about old habits and beliefs, so it was now very difficult not to make the change, but sustain the achievements. Whenever we did not make sure that things were happening as we are planning for, things got back to like older habits. If it's chest X-rays, if it's no kangaroo, etc. Team discomfort. So a lot of the team members did show signs of change and want to join the change, but there are still some stubborn team members. We still hear sometimes from parents about that they were told I'm taking care of the baby, don't touch the baby now, and sentences that are very difficult for them to hear, and we don't want to hear in our unit, but sometimes they're still there. Limited resources, so it's not just the nurse taking out the baby for kangaroo. It's also very difficult to plan, to make sure that integration of new protocols, research. I've tried to get into monitoring better the kangaroo care times within the electronic medical record, and I couldn't get to doing that because there is no time. And recruiting local team members, again, too many projects and not too many volunteers. New challenges. So we're at a better place for sure, but now we want to do even better. And sometimes, so it's challenging from two aspects. Both sometimes the team are feeling that we're pushing too hard because look, we're at a much better place than we've been before, so we don't need to go further. And on the other hand, we are trying now to deal with the minor details. So what I showed earlier, the high acuity area is called room number 1 for historical reasons, and the step down is called room number 4. And everyone's saying room number 1, room number 4, but the parents have no idea what are these rooms. So we're trying now to change the language and call them the high acuity and the step down. And it's very difficult to get to these changes and make those changes. Manpower changes, it's very difficult to have a new member of the team and try to connect him to those goals if he does not feel he wants to be part of it. And in terms of war routine, of course, it's very challenging as well. Hospital pace. I've been trying to get a double lumen UVC to get approved by the hospital for probably more than 9 months now. And it's something that exists in Israel and in other units, but because it's a hospital, everything is very, very slow. I tried to get dimmers for the lights in our NICU, and probably for a few weeks, I tried to understand why we can't get them, and eventually I realized that our lamps don't support dimmers. So again, everything is going very slow. And again, when there's too much on the plate, it's very difficult to implement and sustain. What did facilitate the change? So I think that awareness, I think that the fact that we care and that we want to give our patient a better care is very important. We need to mind the gap, and we need to see the gap, and we need to want to get for it. I think reflection is very important. Both reflect the team, how parents feel, how they see us, how they see their admission, and reflecting to the team how well we've done and how much we've progressed along the time. Persistence, if I had $1 for every time I turned off the lights, knowing that within 2 to 5 minutes someone will say that he can't treat babies in the darkness and he will turn it back on again, I would probably not be a neonatologist anymore. But it's very important to persist and to keep on doing what you believe in. Patience, again, it takes a lot of patience to make a change. It's okay and we need to understand and remember that some team members take their time to join or to get used to the new working methods, and we need to accept it. Set an example. If we do not, as team leaders of this change, if we don't set the example and we do everything as we are trying to get the things done, we can't ask from others to do that. Reassurance, again, I think I mentioned it before, taking the first baby out on skin to skin with an ET tube took me a lot of time, and I had to sit right next to the baby. And it's very important for the nurses, for the teams to know that they're still giving the best care. Teamwork, of course, we are a team. We need to work together, talk about it whenever we can on rounds with the residents, with the nurses, outside the NICU. I think it's very helpful. And manpower changes can be sometimes a benefit, because if a new member joins the team and he does not know what happened before, and that's his new standard, I think that sometimes it's easier to get him along and join the change. What facilitated me during these times, so except the support of my loving family, and a vacation in Thailand is always a good idea. Keep your eyes on the goal. My wife is a long-distance runner, and I learned from her that goals are not achieved very fast, and there are many obstacles along the way, but it's okay. Mind the gap. Again, I mentioned it before, but I think this time it's being able to live with a gap, living with the fact that I know that we can do better, but we are still working on that, and we'll hopefully be there soon. Non-linear progression. So the progression is not linear. For example, after, I don't know, trying to turn the lights on for so many times, after a while I entered the NICU and the lights were off. So that was amazing. Or taking a baby on an ET tube for a kangaroo made it much easier to take babies on CPAP to a kangaroo. So I need to remember that the progression is non-linear. Finding opportunities. So again, if there's a project that is driven by parents, or now we are going into the renovation of a new NICU where everything will be we'll have private rooms, and we'll have dimmed lights, and everything will be towards family-centered care oriented. And I think, again, finding those opportunities is very important. Talk about it. It's not talking to the team, talk to friends, talk to people outside the NICU. And even while preparing this session, I learned a lot about the processes that we went through. It was like a learning experience for me, seeing what milestones did we achieve and what next. And of course, baby steps. We tell it to our parents, it's okay to go slow, and sometimes it's even better to do it this way. Plans for the future. I'm running out of time. I'll be very short. I think we basically need to be smarter, so more specific, measurable, achievable, etc. We have a parent committee, which I've discussed. We need to renew tradition and motivation once Israel hopefully comes to a better place. I think that even normal in Israel is a little bit abnormal, but that's what we have. Palliative care and bereavement I've discussed. NICU renovation I've discussed. Plans for the future, again, specific project, I won't go into them because of a shortage of time. We are very proud of the process that we've done, and I know we've only touched the tip of the iceberg, but we are heading the right direction. I want to thank again both the Family-Centered Care Task Force and our local team for all the work and achievements. And thank you all for listening.
Thank you so much. I feel like it's impossible to state how impressed I am with you and with your team. If you read through the chat, I think you're going to see that that's echoed by pretty much everyone that's listened. So thank you for the work that you've done. We do have a couple of minutes that we can do some questions, if that's okay. One of the first ones that came through from Morgan is a similar question that I had, and that's, how are you encouraging staff when they're feeling burnt out to keep focusing on this, not only in the circumstances that you are in Israel right now, but also just the staffing model that you have? What you're describing is so clinically heavy, and the idea of the nurse to patient ratio of 1 to 6 in your step down unit is just, it's intense. So how do you keep people going?
I don't think I have a good answer for that. I think that that's our reality. I mean, that's what we're used to. I remember that when I went to Canada for a fellowship, I was shocked that the nurse has only put 2 patients. That's what the government pays us for, and that's what people are used to. I mean, we do complain, we do try to make it better. We sometimes have some volunteers. Sometimes the occupational therapist is helping feeding the babies and not doing what she was supposed to do. And we try to gap those gaps whenever possible. We try to push the hospital to enabling us have more nurses. But again, that's reality in Israel, and we have to do the best with what we've had.
I have a feeling that your charisma may be a lot of what motivates your team. You also have a question from Bob. Can you comment more on the support you've received or not received from your hospital administration, and has that changed at all after October 7th?
It received, so I think that I'm trying to, after October 7th, I don't think that much have changed. I think that the entire hospital was in the same place as we were. So a lot of people were recruited. Some of the activity of the hospital was taken down because, like, for a time, non-acute or non-emergency cases were deferred for later times. We are trying to consider the people or the families that are involved, whether I don't know if there is we have a resident that her husband is is recruited to the army, so we enable her to arrive late, or we try to support her, and whenever our psychologist and a social worker try to support her. And I think that there is a lot of support from the community as we are all facing the same challenges. So I think on some, especially in the beginning, there was you felt a lot of support from any surrounding or any circle around you. But again, yeah, there is a lot of burned out throughout this year. It's been very, very challenging.
Well, I think we'll have to move to our next speaker, but I just want to thank you so much. You're truly an inspiration to the rest of us in getting family-centered care as part of our culture. So thank you.
Thank you. Thank you very much.
Well, thank you, Rafi. And I'm Kira Sorrells, and I am delighted to introduce our next speaker, who is a good friend and colleague of mine, Fabiana Bacchini. She is a powerful advocate and a passionate champion for FICare and all NICU families. She's the executive director of the Canadian Premature Babies Foundation. She's also a journalist, a beautiful writer, and published author of From Surviving to Thriving, A Mother's Journey Through Infertility, Loss, and Miracles. I am not going to share her story because it's much better to hear it directly from her. Fabiana?
Oh, thank you. Thank you, Kira, for the introduction. And thanks to FCC for the opportunity for me to present here today. And I want to thank each and every one of you for joining us live. And Rafi, wow, you're such an inspiration. But for me, being part of this group, the FCC task force, has been an amazing experience and really an inspiration for me to continue to do the work that I do every day in Canada. So I'm very grateful for all of you. So there is an intriguing tale from the Andes. Two tribes once found themselves in a conflict. One lived high in the mountains and the other in the lowlands. The mountain people invaded the lowland, kidnapping a baby with the intent of raising it in the mountains as one of their own. The people from the lowlands did not know how to climb the mountain to save the baby, given their unfamiliarity with the mountain terrain and trails. However, they decided to send their most courageous warriors to rescue the baby. After endless days, they had conquered only a few hundred feet. They came to the conclusion that unless you were born on the mountain, you could not climb it. They felt hopeless and prepared to return home. As they were turning to leave, they saw a remarkable sight. The mother was climbing down the mountain they had not been able to conquer, and she wasn't alone. She was carrying the baby strapped to her back. One man asked how she had climbed a seemingly impassable mountain and rescued her child. She shrugged her shoulders and said, "It wasn't your baby." While there is ongoing debate among scientists about the existence of maternal instincts, it's a scientific fact that during pregnancy, breastfeeding, and early child care, parents undergo significant hormonal changes that facilitate caregiving. Oxytocin, often referred to as the hormone love, fosters a deep bond between the parent and the baby. Now imagine the sudden and unprepared arrival of your baby, delivered prematurely, having your baby taken away from you, placed in a plastic box, leaving you in a state of emptiness. Fear, uncertainty, and guilt become our companions. This experience can lead to a sense of identity crisis, leaving us parents unsure of our role, or making crucial decisions, care for our babies, or even touch or hold them. How could a family still bond with their baby in this new environment and feel empowered to care for their child? Well, being a second-time mom and expecting twins, I was ready to climb that mountain to care for my new babies, and I was ready to bond. But this time was different. The death of one of my twins in utero triggered preterm labor, and without any warning or preparation, I was rushed into the operating room and delivered the twins at 26 weeks. Mike was stillborn, and Gabe was whisked away to the NICU before I could even lay my eyes on him. The NICU at Mount Sinai Hospital in Toronto became our home for 146 days. When I finally saw Gabriel, he appeared unlike any baby I had envisioned. He was purple, wrapped in a plastic bag with tubes and wires everywhere. I was shattered, gripped by fear, feeling disconnected from motherhood. Everyone there seemed to know what to do, but I felt I had no place but sit and be an observer. But as the days turned into weeks and Gabriel became somewhat more stable, we were introduced to a transformative research project called Family Integrated Care, or FICare. I immediately became fully involved in Gabriel's care. I had peer support, I had mental health support, and daily education sessions. I not only participated in medical rounds, but I also presented my son at rounds. The nurses became my guides, my coaches. They taught me how to nurture my baby in that challenging environment. And as a family, we felt we were a valued member of the healthcare team and making informed, shared decisions with the team. The journey was very long, full of ups and downs, but gratitude for the team that was working with our family kept me strong and focused on the present moment, as I knew everything could change in an instant. So close to our discharge day, we learned that Gabriel was going to come home on oxygen. It was a very hard information to process, but I was really reassured that I was prepared to take care of him at home. After all, I had spent over 1,100 hours by his bedside, and I participated in over 100 medical rounds. And the reason I know the numbers is because I have my own charts, because we were part of FICare was to have our own paper charts at the time. And less than 2 months after discharge, Gabriel got very sick. He turned blue inside the community hospital, and no one came to rescue him. And all I remember was the parent resource nurse words during our CPR course. When you don't know what to do, we start CPR. And I did. And that day, I saved Gabriel's life. We took this photo just 9 hours later at an intensive care unit at a children's hospital. It was Christmas Eve. And as hard as that day was, I felt so much gratitude. I felt gratitude to Marianne, the nurse who taught me CPR, to the team at Sinai, and to FICare, as I realized that it gave me the know-how, the skills, and the courage to save my baby. And thanks to them, I found my voice to push for Gabriel to be transferred to this children's hospital that night. But the challenge didn't end there. When Gabriel was about 20 months old, he was diagnosed with quadriplegia cerebral palsy. And it doesn't matter where you are in the world, raising a child with special needs means advocating for them. And that is something I've been doing from day one, really guided by the principles of family integrated care. The prematurity journey does not end when our babies get discharged. In fact, the journey ahead is a maze, and most families like mine are still on the fight or flight mode. They are coping with feelings, fears, the baby's health, and some of us who receive new diagnoses have to learn how to navigate another system. Many parents like me have several appointments with brand new teams of specialists and follow-ups. There is often a feeling of loss when we leave the hospital, as we literally lose the hospital support system. We lose the connections that were built in the NICU. But there is hope. When I reflect on my journey, I realize that being involved in my son's care changed my perspective and perceptions of my experience of the NICU. It really laid the foundation for the road ahead, restored my sense of motherhood, and gave me confidence in my caregiving abilities. Through education sessions and medical rounds, I gained knowledge, and I believe that knowledge is power. I felt empowered and confident, and I found my voice to advocate for him. Through peer support and the graduating NICU parents that we had at the hospital, I learned that I was never alone. I saw other parents walking on this road, paving the way for families like mine. I found this new community. And my story is not the only one. Over the last 11 years that I've been volunteer at either Mount Sinai Hospital and in my role at the Canadian Premature Babies Foundation, I've had the privilege of hearing from numerous parents who have experienced the profound impact of actively engaging in their baby's care. So this is a quote from Yasmin. She's a health researcher, and she published her own insights on the impact of FICare when she had a preterm baby. She said the family integrated care model was an unprecedented part of being a parent of premature baby. I was not prepared for my baby to arrive so early. The FICare model mitigated this dilemma by positioning parents to be advocates for their babies from the outset. Or Adrian, she's a parent of a 24-weeker. She said through active participation in medical rounds, inquiring about critical aspects and acquiring essential caregiving skills for our baby, and understand the nuances of monitoring her health, such as interpreting pulse oximeter readings, we gain a sense of confidence through our NICU experience and transitioning to home. Well, having families at the center of care in models such as FICare means hope, hope that families can thrive. Over the last decade, many publications have shown that parents experience significant benefits from greater engagement in care, including enhanced parent-infant attachment, bonding, parental self-efficacy, higher rates of breastfeeding at discharge, lower parental stress and anxiety, less ROP, shorter lengths of stay. And I always ask myself, so we know all that, so why are we not there? We also know there are many publications showing the barriers for parental presence and engagement in the care of their babies in the NICU. from the social determinants of health to the NICU culture. And this group had many sessions about this already. And I feel that while we cannot solve all barriers at once, we can certainly work together to mitigate some of those barriers, restore or implement family-centered care or family-integrated care, and most importantly, empower parents to become their babies' better advocates. And why does this matter? Well, if I were to ask you, why are you in healthcare? I'm sure you'd say it's because you care. And if you care, you certainly want to see our babies thrive like this one in the pictures and live life at its fullest long after discharge. So it matters that we become empowered to care for their little ones. But how? How can we empower parents? What are some steps that need to be in place to get started? And I'm sure some of you here, or many of you, are already doing many of those things that I'm going to share with you. And for you, it will be a reassurance that you are doing the right things for the families that you serve. But first and foremost, it's time that we shift our perspective and understand that the paternalistic approach the hospitals take is no longer an option. It assumes that the hospital owns the baby, allowing parents to visit their babies. So this approach hurts families, and hospital policies should operate under the Hippocratic oath of do no harm. Parents should never, never need to ask for permission to parent their baby. So what can we do? Can you start by perhaps analyzing the signs you have on your NICU doors? Do you need to change the signs to make them more welcoming? Can you work with the leadership team to change how visiting hours do not apply to parents? They apply to friends, extended families. Your NICU team should never say to a parent, when are you coming to visit your baby? Parents are not visitors. Parents are essential caregivers, never visitors. So as part of the FICare research project, parents were asked to highlight times during their hospital stay when there are opportunities to build their capacity and resilience. So they identified these critical beginnings on their journey, and I'll go through them on my next slides. And I believe that you don't need to do them all at once, even though you can run like Rafi did in Israel, but you can take one at a time and perhaps do a quality improvement project one at a time. So the first one is the first few hours after delivery, is reassurance and self-care. Is the mom or the birthing parent well? The second critical period is the immediate postpartum period. It is crucial for someone from the NICU to connect with parents as soon as possible. If you have a welcome package, an orientation video, share with your parents after delivery. Provide a scent cloth or oral immunotherapy kit, the OIT, which acknowledge that the parent is important and part of their baby's care from the beginning. Having a healthcare provider meet with the mom or the birthing parent and show them how to express milk soon after delivery. The first time in the NICU, it is another critical time. It is all about communication, the verbal communication and nonverbal communication. Do parents need to call in before they come into the unit? How are they greeted by the front desk clerks? Are they welcome as parents or visitors? Has someone acknowledged them and asked how they are doing? It is important that they are encouraged to meet their baby rather than just the equipment. Can you show them, for example, if the baby has hair, or show them the little toes and help them see the baby pass the equipment? Over the next few days and weeks, you can partner with parents in the care of their baby. You can help them identifying signs of stability or signs of stress. You can ask them how they think their baby is doing that day. Support skin to skin. We all know the evidence. Being involved in the care of their baby while in the ICU is also crucial. Teach them how to change a diaper, take the temperature, clean their eyes. First, because they will feel like a parent. Second, you will be preparing them to care for their baby at home. They will have a brand new team of healthcare providers in the community, and they will need to share their baby's journey over and over again and become their baby's voice. So parents who were involved in the research study also provided ideas to the research team around how staff could support parents in other ways, teaching parents how to observe first and teach them to understand later. While observing the baby, you can reinforce to parents how the baby responds. For example, if the baby is calm, in a quiet state alert, this would be a great time to sing, read, or talk to the baby, and observe signs of stress. Give the parent time to watch, look, and listen, to reflect on their baby and express more freely their concerns and observations. And teach them to understand at a later stage when they are ready. Teach them the baby's cues beyond the monitor. For example, ask the parents what they see and give them feedback. Ask them if they feel that the baby looks comfortable, is relaxed, suckle their fingers, or is the baby stressed or not in a comfortable position. Take every opportunity as a learning moment. In my case, I learned that Gabriel could turn grayish or blue if it was more severe. I learned to look at him without the monitor, which, as I mentioned before, made me start CPR, and I saved his life just a few weeks after discharge from the NICU. Remember to take baby steps and support parents where they are at. The first steps of involvement might be just limited to just touching or watching, listening, maybe talking, singing, or they could be encouraged to let the baby grasp their finger, maybe a hand hug, or if the baby is magically stable, offer the parent to do skin to skin. So when the baby is held skin to skin, is a great time for parents to notice how the baby is responding to their touch. Teach the parents the importance of this practice. Skin to skin, we all know, is recognized as biomedical intervention, a must-do in the care of preterm and low birth babies in developed and developing countries. Parents will build resilience and confidence as the knowledge of caring for their babies deepens, and it will happen, is a progression. As you can see here, these are the steps for parents to grow from being observers to fully active participants at their own pace. While not every parent might reach the top for various reasons, every parent should have the opportunity to learn about their baby and their baby's condition. Every parent deserves the chance to grow in their role, and we must avoid letting our biases dictate who we think has the potential to reach the top. What we must prevent is leaving parents at the bottom step, not present and not involved. This is harmful both to the baby and to the parents. This principle also applies to parents who don't speak the local language. For example, in Canada, we have a very diverse population, including many immigrants who have limited or no English. So it's very important that we find ways to communicate and engage them. Some hospitals, we have interpreters here in Canada, but some hospitals have multiple languages, or if not, you can use Google Translate, that can certainly help. But at the very least, you can ask parents how they are doing and which questions they have. And you don't have to do this alone. Parents of premature babies are very passionate and open to support you and your work as a healthcare provider. Many of us, as you can see in this call today, will come back to provide peer support, to be in advisory boards, whether it's in person or online. And you have many parent organizations from around the world, and so many in the US, supporting hospitals and filling up gaps in our healthcare systems. And here is just a handful of organizations from many parts of the world. Our organization here in Canada, the Canadian Premature Babies Foundation, was built on the pillars of FICare with focus areas on education and support. So to help hospitals with the FICare implementation based on the critical beginnings pathway that I shared with you, we create evidence-based educational materials for families that are easy to understand, plain language, grade 8 English level, and some materials in multiple languages as you have a high number of immigrants. And we've been working with the indigenous group to create materials for some indigenous communities, and they are culturally adapted. And I'm also happy to share with you that we'll be launching culturally adapted materials for 10 equity deserved communities at the end of this month. And I'm sure this will certainly support many NICUs in Canada and US, as we have a very diverse group of people here. So understanding the impact of peer support, we developed a peer support training, not only for the parents who graduate from the NICU, but also for hospitals on how to bring parents back on a different role. We are currently revamping both trainings with more up-to-date information and lessons learned along the last 10 years. And we'll be launching this training next year. So I want to wrap up by saying that we can no longer turn a blind eye and wait for the next person, the next leadership, the next hospital renovation, or the next budget to start to change. We must instigate a transformation in our healthcare system, and it starts with changing our individual attitudes, which will lead to broader collective shifts. And this shift is only possible when we work together. So it's time for all of you to really work with parent organizations like ours, like the NPN, because we are very motivated, and most of us are working to ensure a transformation in NICU practice by having family integrated into the care of their babies. We all have a role in empowering parents to restore their confidence and ability to climb their own mountain. And I leave with this quote from Dr. Patch Adams: if you treat a patient, you win, you lose. You treat a person, I guarantee you win, no matter the outcome. And always remember that in the NICU, you are not only treating the patient, which is the baby, you are treating the entire family and helping them to grow in their role as parents. So here is my information, and thank you again for this opportunity.
Thank you so much, Fabi, for just all of your work and your advocacy over the years. Could you share a little bit about the Preemie chats that you do? Because I think that would be something that folks would really be interested in.
Yeah, so the Preemie chat is our virtual weekly education session for parents who are currently in the NICU, parents who graduate from the NICU, and for healthcare providers. We've done over 340 sessions to date. Today, we started during COVID, and I'm so grateful that quite a few people in this call today have been part of the Preemie chat, sharing their expertise, their knowledge. And what really excites us is because we have an international audience on the Preemie chats from 150 countries around the world. And we are very privileged to be in Canada, in US, in countries that we have so many resources. But many countries, like many countries in Africa, in Latin America, they log into the Preemie chats to learn from clinicians, scientists, and all these researchers from our countries to learn what we are doing and what could they do. So it became just very, I feel, a democratic platform. It's free to join every Friday, and it's great that we're learning together. So yeah, all the information is on our website, and all the sessions are also recorded and available on the site.
Yeah, absolutely. So if anybody has any questions for Fabi, please go ahead and chat them in. I did want to ask you just a Canadian question about the country itself, and what sorts of challenges in terms of access to care do you see in Canada?
Well, it's a very big country, and all level 3 NICUs are in big cities. So families who live in remote communities, in reserves in Northern Canada, they have to travel long distance, move away from their communities to be in the big city with their babies. So obviously that creates a lot of financial struggle for families. Families are alone, particularly the indigenous communities. They come to the big city, they have to have the support that from their own communities. So it is a challenge, but it's also a challenge going back, getting discharged from the hospital with neonatal follow-up. Those babies fall into massive gaps in our system because they don't have the same care a baby would have from who lives in a big city. So we do have a lot of gaps in Canada. I know US always look up to Canada because you have a universal healthcare system, but we also have a lot of problems.
Yeah.
We have a lot of a very diverse population and a lot of NICUs with a lot of immigrants who don't speak English. So this is becoming something that is in our radar. How can we better support those families that are coming to this country?
Yeah. So we do have a question related to your family peer mentors and the training. That's a training that you developed?
So that
what
training,
does it entail?
So that training was based on the training, the peer support training from Mount Sinai Hospital, because they were pretty much pioneers in this. They created that program over 25 years ago, before peer support was a thing around the world. So we create our training based on theirs, and now we are revamping. So we provide this to a lot of hospitals in Canada when they don't have their own training, or they have a peer training for children's hospital, but not NICU specific. Our is focused on NICU specific. So we train a lot of healthcare providers. Is a day training online that we've been doing since COVID. And it's just how to do it and how to bring parents into the unit on a different role. And besides training the parents to become a peer parent, because we also need to understand is more a listening from that parent with compassion, empathy, rather than sharing our story or vent or, you know, oh, this also happened to me. So how we do some play role scenarios on situations that can happen when you are providing peer support to parents.
So is that available for licensing or purchase for any hospital or organization?
It's all free. All the trainings are free, and we are revamping and relaunching in 2025.
Great. Let's see, we do have a couple of questions. One is, can you speak about your experiences when you started attending and then leading medical rounds during your son's NICU stay?
Oh, that is a great question. This is a progression. And I tell you, I am from Brazil. And in Brazil, we don't have this relationship with doctors like we have in Canada. It is a top-down. So for me, questioning a doctor was out of my radar. Would never do that. So I came with my cultural experience into the NICU with that. So it was very slow. First, I was just sitting, watching rounds happening. And my nurse helped me to prepare. Okay, you can introduce Gabriel. Just say, okay, my son Gabriel was born at 26 weeks, weighing 2 pounds. Now he's whatever weight. So that was my beginning, to the point that I started asking questions. And to the very end, towards the last, I don't know, maybe 2 months, it was when I really start to engage and sharing decisions with the team. So it doesn't happen overnight. It is a progression. Is when you feel more confident also based on my observations. I was there 8 to 10 hours a day in the NICU because I'm a very privileged person that I could be there for this many hours a day. And I watch my son. So I was able to ask questions when they, for example, introduced fortifiers to Gabriel's diet. And I noticed he was having reflux. So I was able to talk to the team because I was there. But the bedside nurse is the key person to work with you, coach you on how to engage in rounds from my personal experience.
Yeah, thank you for sharing that. Another question, Malathi says she really likes your parent empowerment timeline chart. Is that available as an educational piece to share with staff?
That is a great question because it is not available, but it is now on this webinar. But I can certainly share with you because this came out of the FICare research team, and FICare was created with parents. And that chart was 100% created by the parents who were part of the project. So yes, I'm happy to share that because there is a more depth for each one of those steps than what I presented.
Right. And it speaks to what you just said, that there is a progression. I mean, you don't just automatically become an empowered, informed, confident advocate. At least most parents don't. I'm not going to say nobody does, but most parents don't. Well, thank you so much, Fabi. Do we have any other questions? I don't think so. But I just thank you so much for being with us today. It's great to see you. Great to hear about just all the great work that you do.
Thank you.
Yes, thank you so much, Rafi and Fabiana. Both of your presentations were incredible, and I'm so looking forward to going back through and writing up the follow-up email for this. Please take a look at our 2025 webinar schedule. We've got a great speaker lineup. We'll be sending out invitations for these soon. And please don't forget to register for our NICU FCC Measure Survey. If you haven't already, all of this information can be found on our website, fcctaskforce.org, or you're welcome to email myself or Malathi with any questions. Hope everybody has a great day and a good rest of your week.
Thank you.
Thanks.